And joining me now is medical oncologist Dr. Lee Cranmer, who has literally just gotten back from Chicago, where these new findings were announced about these two very promising drugs in treating advanced melanoma. And thank you for joining us.
It's my pleasure, Pam.
Maybe the best place to start is tell us a little bit about the incidence of melanoma and other skin cancers in Arizona. We really do have quite a high incidence here.
That's correct. The very high intensity of ultraviolet light that we experience here, combined with our desert environment, which reflects the ultraviolet light from the desert floor, markedly increases our exposure to ultraviolet light, which, as best as we can tell, is the major modifiable risk factor for skin cancer.
Now, there are two drugs that it was just announced, very promising ones, to help slow the advancement of melanoma in certain cases. And tell us a little bit about that, and why is it such a breakthrough?
Well, that's very correct, and we're very excited about that. We're also very proud of the fact that the Arizona Cancer Center participated in the development of these drugs, one more than the other. But the significance here is that up till now, there have been no drugs with a proven ability to improve the survival of patients who have advanced melanoma, the deadliest form of skin cancer. Now, finally, we've been able to demonstrate, after decades of failures, we have finally shown that we've been able to improve on a drug called dacarbazine, which was approved in 1975 when Gerald Ford was president. It took that long to develop drugs that could outperform dacarbazine and are now able to make an impact in terms of improving the survival of patients with metastatic melanoma.
As you said, you didn't have anything before this. And how long can you prolong someone's life?
Well, that's going to vary from case to case, because melanoma is not just a single disease. There are different types of melanoma. Some are more aggressive than others, and we're really only beginning to scratch the surface of understanding what distinguishes people who have very aggressive disease from those who have much less aggressive disease. In the studies that were performed, improvement in what we measure is the median survival, so that's the survival of half of the patients who've been enrolled in a trial for metastatic melanoma. For ipilimumab, or Yervoy is the trade name, depending on the study that you look at, the improvement in survival is from 2 to 4 months, call it on average. In fact, there are some people who derive a great deal of benefit from this treatment, with their survival seemingly being prolonged for years. There are, of course, other people who don't seem to benefit at all. And that's really where our research is focusing, trying to identify how we can predict the people who can most benefit from the drug, and also try to figure out how we can get the people who aren't benefiting to derive benefit.
Tell us a little bit about these two drugs and how they work.
Well, ipilimumab, which we've spent a great deal of time working on, is a drug that attempts to induce the immune system to recognize the cancer. We've known for a long time that the immune system and melanoma were intimately interrelated, and as a consequence, a great deal of work has been undertaken trying to look at immune treatments for melanoma. And this is a breakthrough in demonstrating that, in fact, that idea, which is very attractive, using the body's own defenses to attack this disease, is in fact capable of producing results. The downside is that in doing this, the side effects of the drug reflect its mechanism of action. So the body, or rather the immune system, can begin attacking things that it isn't supposed to attack, for example, the colon, the joints, the nerves, the liver. It can start causing these, what we call autoimmune side effects of this particular drug. But they reflect the actual mechanism of action, because in the process we hope that the immune system also attacks the melanoma that's distributed through the patient's body. The other drug, with the long and difficult to pronounce name vemurafenib, which took me a while to learn to pronounce, it targets a genetic mutation which is peculiar to the melanoma cells in a given patient's body. So it really can be the target of, you might almost say, a silver bullet therapy. The only place in a patient's body with this mutation is the melanoma cells, the things that you want to attack. The downside is that this particular mutation is only present in about 50% of patients. But when it's present and we use this particular drug in those patients, you can have very, very dramatic responses to the treatment. The downside of this particular drug is that the responses are not durable.
We just have about 30 seconds left, doctor, but they may use these drugs together. It may show to be very effective using them together. But you say we have a long way to go in terms of understanding these drugs and treating people with them, although they are available right now for treatment.
Indeed, they are. Ipilimumab, or Yervoy, is actually prescribed at our center. It is an FDA-approved drug at this point. Vemurafenib soon will be approved, undoubtedly. But how to use them best still remains unknown. Combining them actually does make some sense. And certainly we're not at the point of mission accomplished, if you will. There's still a great deal of work to be done for melanoma. But the great news is for our melanoma patients is while the future, we don't know the future in detail, a future without effective treatments is not the future.
Well, thank you very much for joining us today. I really appreciate you.
It's my pleasure, Pam.